Well, welcome everybody. What an exciting day. Here we're in Pensacola, Florida. It's a gorgeous day here. And most of you know I practice in Michigan, and we're proud to be able to say that we could get back to work on Friday, and I'll be back in the office on Monday. So it's kind of an exciting time to get back into dentistry. Today's topic I think is pretty interesting because I know implant dentistry is a very hot field. But there's also some concerns and trepidations about what can and can't be done. So what Dr. Tilley and I wanted to do today was kind of go through some of the steps that we use in creating full aesthetics and prosthetics, emergence profile, etc. So we entitled our program Surgical Pathways for Implant Dentistry. And so why don't we go ahead and begin? So our objectives today, we sat down with Damon and tried to come up with some nice objectives. We're going to show how to treatment plan the right surgical site for implant placement. Questions are often asked, when do we do a reflection? Or when do we do a flapless procedure? And we'll kind of talk about that over the next hour and a half. We'll talk about flap and flapless placement. And then sinus tenting procedures, another interesting topic that Dr. Tilley will show a beautiful case that she created on how we're able to actually lift the Schneiderian membrane and go ahead and place a dental implant in a more challenging situation. I think you'll really enjoy her part of the program. Anterior implant placement. There are certain rules that must be followed in placing anterior implants. So we're going to go into some details about how we can create interdental papilla and manage or save interseptal bone, which is very, very important. The cost of doing business with implant dentistry, I think that's a very important part, and I'm going to go back and talk about how to develop fees and how to make implant dentistry the most profitable dental procedure that you can do in your practice. So dental implants, definitely in the realm of treatment of the general dentist. I don't think there's any question about that. I think we are the gatekeepers. I think we understand aesthetics, we understand emergence profile, and when properly trained, and I will state that it's very, very important that doctors learn the proper techniques and protocol to idealize their case. So that means learning the steps, create predictability, and create an excellent functional and aesthetic result. And I know our second speaker, Dr. Todd Engel, is a dear friend of mine, and I teach with him at the Engel Institute in Charlotte, North Carolina. And his programs are just outstanding live patient programs. So I'm sure Todd will talk a little bit about that later. Conventional implant dentistry is within the scope of the GP, but we have to take out the mystery, the apprehension, and angst. We have to increase your confidence and increase your competence and make this a very viable treatment plan or treatment modality in your practice. So how do we build an implant? How do we build implant competency? Well, education. As was mentioned, I'm very active in the Academy of General Dentistry, serving as the associate editor. And I'm a big believer in educating ourselves. I still, to this day, take a lot of continuing education courses, and I applaud you all for taking your afternoon and listening to us on some very, very important topics as far as implant dentistry. But I also truly believe that practicing on hands-on techniques is very, very important. And I'm very excited about dentistry. I also work with Glidewell Lab and the programs that we're doing with them, the online education programs, I think are wonderful to learn. And the virtual learning that we're doing right now, I think is very, very helpful. We have some exciting, I think we're going to have some exciting things coming up in the next year, which I think we will all appreciate. So let's talk about, let's begin. Let's go right into clinical. That's what we're really interested in seeing. So when do we flap and when do we reflect? That's a great question. Well, a flapless procedure is less invasive because we're simply removing the tissue off of our surgical site. where a reflection or a flap procedure, meaning we're actually taking a scalpel or some type of instrument and pulling the tissue away from the bone or the hard tissue. When we're not sure, doctors, when you're not sure, when it's not a slam dunk, when we don't have plenty of vertical height and adequate width of hard tissue, then we want to reflect so that we can actually see the site. So here's a patient, same patient, contralateral areas of the mouth. And what we all first do is patient comes in missing a tooth and certainly wants to have some type of tooth replacement. Now we do have differential diagnosis. What can we do? We can do a 3-unit bridge here. We could do nothing. We could make some kind of removable appliance. But obviously dental implants is a viable alternative in today's environment. Our patients become very, very well educated. You know, certainly they are Google searching. If they're missing a tooth, if they have a toothache, or they hate their denture, or hate their partial, they're Google searching, and what's going to come up? Dental implants. So I think it's imperative that we become proficient in educating our patients as to the benefits and the risks of implant dentistry. So here we're just taking a simple periapical radiograph to determine a couple things. Number one, do we have adequate height of bone or hard tissue to work with? And I think all of us looking at this would say, yeah, it looks like there's plenty of bone there. There's no sinus or anything involved. What about mesial distal width? Well, your x-ray on the left side looks like we may have adequate room for a tooth. On the right side, maybe not so much. But again, a lot of this has to do with the angulation of the radiograph that we're taking. So this is our preliminary determination of whether or not the patient is even a candidate. Obviously, we're also looking at the health of the patient. We're looking at their past dental history in determining what's correct. So where I would begin is to determine the amount of available hard tissue or bone that we have. I will take a 5mm ball bearing. We purchased these from Salvin Dental in Charlotte, North Carolina. And we simply fill it with some orthodontic wax. And we're simply putting this 5mm ball bearing, it's very precise, in the edentulous space. And this will allow us to actually make a measurement. And you can see how the radiographs change depending on the angulation of the radiograph, of the angulation of the DEXA sensor. So we use DEXA in our practice, and I think most of the digital radiographs have some type of measuring tool. And this measuring tool allows us to actually determine the width of the ball bearing that we place in the orthodontic wax in the edentulous space. And we simply drew that, the ball bearing, and we know that it's a 5mm ball bearing. Now, we don't go to Cabela's and we don't get BBs or things like that. We have to know precisely these are surgical ball bearings of known diameter. So pretty simple with most systems, you can certainly learn that. Then from there, we can eliminate foreshortening and elongation of our radiographs. Again, because the radiograph can change the position. And again, using my measuring tool, I can actually measure from the crest of the ridge to the apical portion of the adjacent teeth. That is usually my guide of how long an implant I could possibly place. That's a very safe way of doing it, especially in the posterior mandible, where if I look at the apices of the adjacent teeth, it helps me to determine a safe method of placing my dental implant or a safe size of implant. So here you can see the left screen, we have nearly 17mm of available height of bone, which is a lot. On the contralateral side, we have over 15mm of available hard tissue. Now, I wouldn't necessarily put a 15 or 16 or 20mm implant in that area. With the particular implant that we're going to use here is from Glidewell Lab. It's called the Han implant system. And they come in sizes of 8, 10, 11.5, 13, and 16mm in length. Again, we want to be safe. We want to be sure. These high quality implants will allow us to functionally and aesthetically restore an edentulous area quite effectively. So using our digital radiographs, we have available height of bone, but do we have available width of bone? And that's the question that we have to have. So again, using that same ruler, we can actually measure the distance mesial distally we have in that edentulous space. And we have nearly 6 millimeters. Now, the rules of thumb with our dental implants are very precise and very accurate. We should not be any closer than 2 millimeters from an adjacent PDL. That's in the literature, it's very physiologic. The PDL has blood supply and nerves, and we want to be at least 2 millimeters from the adjacent PDL. If we have two implants next to each other, those implants must be spaced at least 3 millimeters apart. Why? Because there's no PDL, there's no blood supply around that area. Now we have a distal crown on the left-hand screen, and obviously we could contour that crown. The point being is, and this is important, we're thinking tooth up. As general practitioners, we understand the emergence profile and aesthetics that we want to create. It's more than just placing this titanium spark plug in the jaw. We're thinking tooth up in this situation. And when you train your mind to do that, all your cases will be ideal. You won't make mistakes. You won't have the prosthetic challenges we often have with our implant dentistry today. So we have to be very conscious of the amount of space we have mesial distally and vertically. Finally, we have to determine facial palatal width. Now, how do we do that, doctors? Well, CBCT analysis is really a wonderful tool. I've been doing dentistry a long time, and I remember when the panoramic radiograph came out, that was pretty high tech. This is an instrument or tool that is going to make you much more proficient. Now, that doesn't mean you have to run out and buy one, but there are enough centers around that are taking dental CBCTs for you. There's mobile units and things like that. So you need a CT analysis when you need it. So if you're uncertain, then I think it's worth the investment. It's worth for the patient to make the investment in the CBCT analysis. And here, when we're looking at it, we can actually see a sagittal view. This happens to be a Vatek CBCT, which I love, very high quality. For those of you who may be interested, you may want to look into that. But we have nearly 8 millimeters of available hard tissue, facial to palatal. So that allows us to be able to place an implant very, very efficiently. Doctors, you can't be giving these cases away. These are cases certainly within your realm. We want at least a millimeter, minimally a millimeter of facial bone and palatal bone. So let's do the math. If we have 7.7 millimeters of available width here, take away 2, we have 5.7 millimeters for titanium. Now, we don't necessarily want to put that wide of an implant in. In the bicuspid area, I would normally put a 3.5 diameter implant in. When I started years and years ago in implant dentistry, we used to say we put the longest, fattest implant in we can in a certain situation. That is not the case anymore. Our engineering principles, our design of our implants is very, very sophisticated today. And we want less titanium, more bone. So if I simply place a 3.5 diameter implant here, 3.5, 4.5, 5.5, 6.5, 7.5, theoretically, I could have 2 millimeters of a natural bone on the facial and palatal aspect. These are cases that certainly you will want to do in your practice. On the contralateral side, we have even more, 9.4 millimeters of available bone from the facial to the palatal aspect. So again, situations that are within the realm of the general practitioner. Again, I'm going to go back. When do we flap? When do we do a reflection? Well, if you're unsure, then you want to reflect. When you reflect, you can actually see the hard tissue. When we're doing a flapless procedure, we're kind of blind because we can't see through the soft tissue onto the bone. But I'm going to show you those techniques in a moment. So we want to idealize, as I mentioned, we want to think tooth up in these situations. And one of the considerations that we must always make is that we must have a band of attached gingiva on the facial aspect of all our implants. At least a 2 mm band of attached gingiva on the facial aspect of our dental implants. So how do we determine that? Well, by simply infiltrating this site, we can see the mucogingival line. It'll show up. Mucosa will bubble up or blow up like a balloon, where attached gingiva will not. So if we look at the left-hand screen, I took a little Sharpie and drew lines so that I could parallel my implant. But it appears that we're going to have an adequate band of attached gingiva on the facial aspect of our implants. On the right side, I just wanted to demonstrate a reflection. Could we do this without reflecting it? Of course. So here I've taken an Orban knife, which is a sharp stainless steel blade of a very specific contour, which will allow me to make what I like to refer to as an envelope flap up. Take a number 10 envelope, lift the flap up and blow into it. So I'm not making any vertical incisions into the attached gingiva. We want to keep our incisions in attached gingiva and not incise into mucosa. When we incise into mucosa, we create prostaglandin and histamine release, and that's where our patients will have discomfort. So I'm simply taking this specially contoured blade, going around the tooth and reflecting the tissue so that I can see the hard tissue. Makes it a little bit easier for me to place the implant. And as I said, when we're making a reflection, I'm not making any vertical incisions whatsoever. We're doing what's called a envelope reflection. So I have complete control. I can see the ridge very, very clearly. There's really no guesswork. Now with the Han dental implant system from Glidewell, the first burr we use is called a pilot burr. It's the most important burr in the mouth. It's a 2.4 diameter burr, very, very sharp. And this allows me to determine both mesial distal and buccal palatal angulation. This is the burr that you will check your positioning. Doctors, if we use this burr properly, you can't make a mistake. You can't possibly improperly angle your dental implant, which eliminates the prosthetic concerns that many of us have in practice. So I'm simply taking this 2.4 diameter pilot burr, drilling to a small amount so I can see my angulation, and simply take a radiograph. And what am I looking at, doctors? I'm looking at my mesial distal angulation on the radiograph. My dark spaces on either side, are they correct? Am I happy with the angulation of the subsequent implant? I'm thinking tooth up in this situation. With a flapless procedure, I will then take what we call a tissue punch. Again, this is from Salvin Dental. They come in various sizes. And this will remove the soft tissue in my surgical site. It's a very high quality stainless steel blade that will make an incision all the way to the hard tissue. I will simply take that plug out. Now I can see my bone through that little tunnel, and you can see my initial access opening. Very, very non-invasive procedure. And because we're not disrupting the mucosal tissue, very, very little postoperative discomfort in these cases. Then I'm simply going to widen my osteotomy. In the Han system, I will use a 3.0 diameter burr, parallel walls, and I will measure, here we're going to use a 13 millimeter implant. I will be able to with radiographs, determine my position through the soft tissue in the hard tissue. But in a reflected situation, I can actually see the very clear line and go right to the crest of the ridge. So you can see where a reflection kind of gives me a little more confidence in positioning, although a flapless procedure is a little bit less invasive for the patient with no sutures. And again, I will stop and take a radiograph and look at my positioning. This is the 3.0 diameter osteotomy burr. You can see the little notch, and we will determine position angulation radiographically. Mesial distal, are my dark spaces equal? Am I thinking tooth up? in this situation am I thinking emergence profile coming out of that edentulous ridge? I'm then going to widen my osteotomy, okay? And this is a 3.5 diameter osteotomy burr, and you can see that it's tapered. It's tapered. I'm going to place this burr into my osteotomy to the correct position. We will verify it radiographically. And again, with a reflected procedure, it makes it a lot easier because I can actually see the hard tissue, and the widest part of that osteotomy burr will be placed at the crest of the ridge. But again, stop. Take a radiograph and make sure you're happy with your positioning. Are you away from the natural teeth, the natural PDL? The rules must be followed. This will give you a lot of safety. And here we will simply insert the implant into the bone area to proper position, verify it radiographically, check the torque. Now, the literature will say that if we're able to torque an implant at 25 Newton centimeters, we can place what we call a healing abutment. A healing abutment is simply a longer screw that penetrates through the soft tissue, which allows the soft tissue to form a cuff around that healing abutment. This eliminates the need for a secondary tissue removal to find the implant later. Theoretically, the literature will say if we get to 35 Newton centimeters of torque, we can immediately load the implant. I don't immediately load very many of my implants, but I just wanted to show that in a very small space, we were able to get outstanding initial stability and torque. So that being the case, I will put 3 millimeter tall healing abutments into each of the implants. And you can see the difference between a flapless procedure. It's very, very non-invasive. There's basically no bleeding. Very rare to have any discomfort whatsoever. Where in the reflected area, we have to then suture that reflected tissue back into position. We torque those healing abutments with the Hans system at 25 Newton centimeters. That will eliminate those healing abutments from ever coming loose. And then we verify it radiographically. Are we happy with the position of those implants? Are we thinking emergence profile? Are we thinking tooth up in this situation? And the answer is yes. So in the reflected area, I will simply do a couple interrupted sutures to close that tissue into position. For education, our postoperative CBCT analysis of each circumstance illustrates that we have at least a millimeter or more of facial plate of bone, which is very, very important in both situations. And this is going to eliminate any grayness or shadowing that you sometimes see with our dental implants that are improperly placed. And here's a little short video. After the tissue is healed, after 4 months of integration, you can see we basically have the same result. We form a nice tissue cuff, which is periodontally sound. We have a band of attached gingiva. Here we'll put our scanning pins in, and we will scan digitally, and we will send this information in this situation to Glidewell Lab. And essentially we can have abutments and crowns or screw retained implant crowns in about 3 days from the dental laboratory. So this is a very, very proficient, efficient, and fun way of doing dentistry. The patient's perspective. We place these are Bruxer zirconia crowns that are screw retained, and we cover the screw holes with composite. And again, we take our final radiograph to ensure a positive seat, and we're able to create form and function and aesthetics to our patients, and they're thrilled with the result. This is what dentistry is all about. Doctors, you must get involved in these surgical procedures. This is something that, again, is financially rewarding and a lot of fun for us. So let's talk about fees. Implant dentistry is certainly one of the most financially rewarding therapies we provide. Breaking down the dentist's costs, however, helps us better prepare our patients to budget themselves. Everybody's on a budget today. It doesn't matter what we have or don't have. All our patients are on a budget. So it's imperative that you work within the patient's budget to provide them the best service. They want this work, so let's break down costs. The average fees for surgical and prosthetic construction over implants vary depending on a lot of factors. The overhead of your office. Do you know what the overhead of your office is? What does it cost you to run your practice per hour? I was hoping we were off for 9 weeks, that would have been a great time to break down the numbers so that you understand all the effects, your staff time, your material time, and things like that, I think are very, very important. Competency and time needed to perform the procedures. I may do a procedure, it may take me 15 minutes. It may take Dr. Tilley half an hour. So we have to weigh that into our profit margins with our final procedures. Implant costs, different brands. There's a range in implants today. Prosthetic component costs. Now the costs of our implants and our crown and bridge has come way down. So I think it's very important that we understand that and break down the fees. We want high quality dentistry at a fair price for our patients. If we're able to do that, we are going to be extremely busy with our implant dentistry. Laboratory charges, and oftentimes patients want credit. They want to know, being from Detroit, automotive, talking to our automotive dealers, they will tell me that 95% of people buying cars could care less what that car costs. What do they care about? The monthly payment. And so we have to be realistic in understanding those responsibilities that we have as business people and make it affordable, give high quality at a fair price, and you're going to be very busy. There's a significant investment in the purchasing of surgical tools needed to perform the surgery, a motor, surgical kit, sterile saline, inventory of dental implants. Those have to be considered. But I can challenge you to tell you that this initial investment is usually paid for after your first 3 cases. And so it becomes very profitable afterwards. Those kits, surgical tray, and an inventory of implants could range $10,000 or more, but it's paid for in only a few cases. So let's just do another case really quick. Here we have a case, a tooth that is deemed non-restorable, probably a vertical fracture, mobile and symptomatic. We happen to remove this tooth and I grafted it, okay? And after a period of time, we determine, okay, it's time for us to place a dental implant. And we can do a grafting webinar at another date, another time, Damon, if you like. But again, same protocol. I have a ball bearing of known diameter. We take our DEXA sensor and we determine, do we have enough vertical height of bone to accept a dental implant? And we measure almost 13 millimeters. So I'm going to say yes. We placed our dental implant ideally, and we're able to place a healing abutment. You can see the periodontal health that's created with our healing abutment after a very short amount of time. Our dental laboratory then fabricated, in this situation, a custom titanium abutment with my margins at or ever slightly subgingival. We're able to torque that abutment into position so that it never comes loose. With the Hans system, we torque it to 35 Newton centimeters, and we fabricate a nice Bruxer crown. And we're able to create form and function, emergence profile, second to none in this situation. Take our final radiograph to ensure proper position. So let's look at costs. Dental implants, big range in costs, from $160 for a Han implant system to almost $400 with some other systems that are out there. We have to take an impression. Most of us out there, I assume, are taking impressions of implants that are placed. There's a cost to those components. Laboratory charges for a custom abutment in titanium or zirconia can range from $200 to $300, depending on which lab you're working with. A Bruxer crown, our crown fees have come way down, range from $120 to $155 a unit. Soft tissue model work, usually around $100, $90 to $100. Our impression materials, our impression tray costs us something, and that averages around $40. So be very conscious of it. Total cost out of pocket for you to place an implant, to impress and make an abutment and crown can range from the $650 to $1,020 per single implant. So what do we charge for that? Well, you have to look at your overhead, and overhead is determined by staff time, any transitional appliances that you make, an esthetics retainer, a flipper type of appliance, whatever type of transitional appliance you decide to make, there's going to be costs that you're going to pass on to the patient. And overhead in many offices is about $400 an hour. So how long is it going to take you to do this procedure? So let's look at material costs, implant costs, lab costs, and your overhead for an hour can range from $1,050 to $1,420. Be realistic. You need to calculate those numbers. Now, many of our patients elect to get credit to pay for these procedures. And the advantage of that is we get paid right up front. I love that. I love getting paid up front. I don't like giving credit to my patients from the office. But we're charged for that ability to get our money up front. And it can range from nearly 6% to almost 15%. So be very conscious of that our cost of the procedure could add up to an additional $500 sometimes. And it all depends on the length of the contract and the patient's credit history and things like that. It's a cut in percentage of profit, but it's worth it if you're able to do these cases. Normally, if you increase the amount of the loan, our costs are diminished. So be very conscious of it. There's a lot of companies that will be happy, Green Sky, Care Credit, et cetera, that will be happy to work with your patients. So I just want to break some numbers. These are averages. You know, we're not supposed to talk about actual costs, but let's say an average cost for an implant, abutment, and crown. We're not talking about extraction. We're not talking about grafting. Those are separate entities. An average around the country, I'm just throwing a number out at $3,500. It costs us, as we mentioned, about $1,050. Insurance, if the patient has insurance, $1,000 a year, $1,500 a year. But let's say we're financing it too at the highest rate, nearly 15%. Now, if we take an office with an average gross income of about $1 million, most offices, most lecturers will tell you that overhead is usually about 70% of your gross income. It's how it's calculated. To me, in my practice, overhead is everything except what I take home. And that's how I calculate my, my net profit. So let's just look at some numbers just for fun. If you did $1 million practice and your overhead is 70%, our profit is $300,000, a good living. Profit margin is 30%. If you were able to do one implant per week for 50 weeks a year, one implant a week for 50 weeks a year, we're going to increase our income, assuming that we have an average cost of implant, abutment, and crown. $3,500 times 50 is $175,000. Let's assume that every patient took credit at the highest percentage rate, nearly 15%. That's costs out of pocket of over $18,000. Procedure fees, we talked about the numbers, and you need to know these numbers, doctor. Costs for the implant, etc. Again, that's cost out of pocket, over $32,000. But it gives us a profit of 70%. This is the most profitable thing you can do in your practice today, doctors. Increasing your revenue $123,000. So your profit margin goes from 30% to nearly 40%. That is significant in daily life. And it's a lot of fun to be able to treat our patients. So our profit increased nearly $124,000, and you have a profit margin of about 70% on average with your implant procedures. So be very conscious of that. But be aware, the financial partners, they do it differently. Some companies act like a revolving line of credit, same as cash, interest-free, where the patients charge a flat rate. You will have a merchant fee, varies from 6% to nearly 15%. Others make it more like a loan, like buying a car. Others make it like buying something at Macy's. So be very conscious of what works best, and different companies actually will work better for different patients depending on their financial situation. So the average fee for a single dental implant, abutment crown, obviously varies significantly from area to area, but when we consider the cost of an oral exam, a full mouth series, the implant, charges for the abutment and crown range from $3,500 to $4,500 in certain situations. But if you're extracting and grafting and putting membranes and doing a CBC, a T analysis, and maybe doing surgical guides, what Dr. Ingle's going to talk about next, you could add the cost to the patient of another $1,500. But our costs, our expenses, average between $550 and $600. So you can see, again, the profit margin increases significantly. So if we charge $3,500 and our cost, overhead included, is $1,050, it's $2,400 profit in an hour procedure. If you charge more, depending on your area, our profit margin increases even more. If you're going to do extractions, grafting, and implant, abutment, and crown, our profit margin increases even more. So be very conscious of that. If you do a screw retain crown instead of a abutment and a cement-on crown, we can decrease our costs another $100. And it's a nice, efficient way of handling a situation. We get a nice tissue cuff and a screw retain implant restoration, screw retain, and then we'll fill this access hole with composite very effectively. Digital impressions can decrease your cost by another $150, and the turnover is faster. As I said, it could take, you could have an abutment and crown in 3 days from many labs. So we do our digital scanning, as I demonstrated earlier. It's immediately sent to the laboratory. Here they fabricated a nice custom abutment with margins at or slightly subgingival and a nice cement-on Bruxer crown. Guided surgery, there's going to be additional charges, but those are passed on to the patient. And it's just going to make you more proficient and efficient. It's a tool that makes the surgical procedures go that much quicker. And the profit margin is still significant. You have cost of the guide that you pass on to the patient, but the chair time to do these surgical procedures is dramatically decreased. And again, Dr. Ingle is going to talk about CBCT analysis, but we're able to virtually design, place our implants prior to any surgical intervention. It's a very, very efficient way of placing our dental implants very efficiently, effectively, with a high sense of predictability. My abutments and our final Bruxer, this is a cement-on prosthesis. So the benefits, 80% of GPs produce less than $375 an hour per the literature. Even with 1 hour scheduled for surgical placement and 1 hour for restorative appointments to complete one dental implant, the hourly production is about 3 to 5 times the highest usual hourly production rate. So that's significant, doctors. Average production in an office, according to literature, is $375 an hour versus $1,000 or $1,500 or $2,000 per hour. 3, 4, 5 times your profit margin. So it's an exciting time to be a dentist, and it's an exciting time for you to get involved in implant dentistry. A lot of educational opportunities out there, a lot of opportunities to actually work on live patients. You can work less hours to make this your same goals, or you can increase your revenue dramatically. So it's exciting. Now it's going to be my honor to introduce a dear, dear friend of mine, Dr. Stephanie Tilley. I'm very proud of her. She is one of the most paramount dentists here in Pensacola, Florida. Very, very talented in many aspects, and has incorporated dental implant into her practice. She published this article in Dentistry Today, and so I'm going to introduce Dr. Tilley, and she's going to do her magic. Dr. Tilley.
Hello, everyone. Hope everyone's doing well today. We'll go through this quickly because I know time's of the essence. We're going to discuss, in this case presentation, a simple sinus bump procedure where there's an inadequate height of available bone for dental implant placement. It's common to see large sinus spaces in the edentulous maxillary posterior region, where we wish to consider dental implant placement and implant retained crown fabrication. Tooth roots act like a tent pole holding up a circus tent in this region. Removing the tooth or the tent pole results in the circus tent or sinus floor to collapse, resulting in a larger sinus area and minimal bone for implant placement. We all know that when teeth are removed, bone will shrink up and in, so placement in this area can be challenging. However, when there is some adequate bone to work with, it is possible to physically lift the Schneiderian membrane without perforating it and lift the sinus floor to create adequate bone height for our surgical placement of a dental implant. This periapical radiograph illustrates in 2 dimensions the potential available bone height. Using my DEXA sensor and measuring device, we estimate only 5.2 millimeters of available bone to place an implant. The posterior part of the mouth takes the greatest amount of force, so we necessarily need to have a properly designed implant that is wide and long enough to compensate for these forces. Appropriate crown and root ratio must be respected. 3 rooted molars help compensate for those occlusal forces naturally. So if we use the analogy of a nutcracker to open a nut, where do we put the nut? In the back part of the device. Same holds true here. We don't want to place an inadequately shaped implant in this area. Proper form and function must be considered. The CBCT analysis is a very useful tool to visualize more accurately the amount of available bone. The sagittal view demonstrated here clearly illustrates that we can actually have about 6.7 millimeters of bone height from the crest of the ridge to the floor of the sinus, and 8 millimeters of available width of bone. Understanding our ability to tent the sinus floor, we can lift the sinus 3 millimeters predictably without perforating the Schneiderian membrane. This is a simple and predictable method of placing the proper width and length of a dental implant. An intraoral view of the edentulous space appears to provide adequate width for an implant and implant retained crown. Again, a CBCT analysis is an ideal tool to determine this fact. We can also determine available bone width by using a bone caliper. We must use anesthesia to the area before we use the caliper to make comfort for the patient. Height can only be guessed using a 2-dimensional radiograph, but we can precisely determine using the CBCT. We should consider taking a tooth-up approach to implant placement. That means visualizing what the final crown will look like, then idealizing the implant position to maximize the final aesthetic and functional result. Using the Hahn implant system here from Glidewell Dental Lab, I have determined I would like to create an 8 to 10 millimeter wide crown from mesial to distal. My positioning of the 2.4 millimeter diameter pilot burr helps me establish mesial, distal, and buccal palatal position. Following anesthetic infiltration, I use the pilot burr to create my initial osteotomy, about 4 millimeters into available bone. This helps me visualize final emergence. A digital radiograph is made. Again, I only penetrated into the hard tissue about 4 millimeters. The Hahn surgical burrs allow me to accurately see this. I'm satisfied with my angulation and distance from the adjacent natural tooth. If I was not satisfied, I could reposition this pilot burr to achieve the placement I desire. Again, using my measuring tool with the DEXA system, I am simply confirming that I am 4 millimeters in available natural bone. We can certainly control our surgical handpiece well enough to place the burr at a position within 1 millimeter of the perceived sinus floor. It appears in this 2-dimensional image that I'm about 1 millimeter from perforating the sinus. I measured the distance from the distal aspect of the second bicuspid to the center of this all-important pilot burr to be 4 millimeters. This means I can create an 8 millimeter wide implant crown. Next in the Hahn system, I will use the pre-measured 3 millimeter osteotomy burr. Again, there is a clear delineated line on the burr, which helps me control position. This is an 8 mm long burr, so I am compensating for 2 mm of soft tissue. I created my osteotomy and can see where I stopped, short of the 8 mm line on the burr, but at the same time maintaining my angulation created by the pilot burr. I can feel that I have not perforated the sinus floor at this point. The radiograph clearly demonstrates the line at the soft tissue height and the angulation of the burr. Going back to my measuring device, the 8 mm burr is measured and I can verify my positioning. Tissue height is approximately 2.5 mm and can be accurately measured. I'm still in good position to create my 8 mm mesially, distally, wide implant retained crown. A tissue punch is used to remove the epithelial tissue over my osteotomy site. In my final preparation, I do not want to push epithelial tissue into the osteotomy. This can result in failure of the implant. The burr is purchased from Salvin Dental in Charlotte. It is simply a circular stainless steel burr. The tissue punch removes the epithelial tissue effectively. With slight pressure, the burr penetrates the epithelium. The cleanly incised epithelium is easily removed with a tissue forceps. The Hahn system has an osteotome kit that matches the shape of the Hahn dental implants. There are tools for the 3.0, the 3.5, the 4.3, and the 5.0 implant. Since I have control of the situation and I know that I had 5 to 6 mm of available bone from the crest of the ridge to the sinus floor, I can now use the osteotome to elevate the sinus floor up to 3 mm without tearing the Schneiderian membrane. This osteotome also has the advantage of condensing the softer medullary bone, providing more of a stable implant placement. Using a wider osteotomy burr would simply remove more bone. The osteotome is condensing the bone. I am able to control my angulation and position. Another digital radiograph illustrates my positioning and the lifting of the sinus floor. Again, easy measurements can be made. I measured 10 mm from the soft tissue height. This means now that I am now 8 mm into available bone, lifting the sinus floor about 3 mm without perforation. I can confirm my distance from the tooth to the center of my preparation. I'm always checking my position radiographically to ensure that I'm going to be able to create a nice implant retained crown. I repeat the process with a wider osteotomy burr, then with my wider osteotomy burr to accept my final implant. Depth is consistently monitored and visualized. The final osteotomy burr continues to condense the bone. Now I can feel here that I did not perforate the sinus floor, but if you happen to do that, it is not overly concerning. However, if you do perforate, do so with the smallest diameter burr or osteotome. Subsequent preparation should thus be made shorter. A Newport Biologics resorbable membrane is cut into a circle and will be placed into our created osteotomy site. This material will become our new sinus floor and will act like a parachute as we add some graft material. The membrane is passively placed. Newport Biologics allograft material is wetted with sterile saline and easily placed into the socket site. A small amount of material is needed. The graft is in place. The graft is carefully condensed into the surgical site. I'm not heavily packing, rather I would let the final osteotome push the material up. A 5.0 by 8 mm Hahn dental implant will then be placed into the site. You can thread the implant into place by hand or by using an implant handpiece at a slow speed of 25 RPM. The implant is then torqued to place using a torque wrench. Final position of the implant is verified radiographically. We want the implant to be placed at the crest of the ridge, so several radiographs may be needed to be sure of your final position. This implant was actually torqued to 45 Newton centimeters, which is impressive in this area where there is soft medullary bone. We created height with our simple sinus tinting procedure. I decided to bury the implant to allow for uninterrupted osseointegration of the implant. A cover screw is hand tightened into the implant. I took a final radiograph that illustrates the final implant placement. Our measuring tool illustrates an 8 millimeter implant. Lifting the sinus floor approximately 2.28 millimeters was done and verified. I have 4.22 millimeters from the distal aspect of the bicuspid to the center of my implant, which allows for approximately 8.5 millimeter wide implant retained crown. A CBCT analysis verifies the implant position and the clear tinting of the sinus floor. After approximately 4 months of integration, the implant is exposed and an impression made. The lab then created a screw-retained implant crown. The access hole is covered with a small piece of cotton or Teflon tape and restored with composite. The final CBCT sagittal view demonstrates the integration of the implant. This technique demonstrated a very controlled procedure within the realm of the general practitioner. However, it is imperative that when doing one-stage grafting and immediate implant procedure, at least 70% of the implant must be seated in the patient's natural bone, with the apical portion of the implant in the grafted sinus area. Hopefully, this technique with proper instrumentation will give you the confidence to start this procedure in your office next week. I highly recommend you go take classes with Dr. Kaczynski with the Glidewell lab. It does wonders for your education and your technique in your office.
Thank you, Dr. Tilley. Great case. Really, really great. So we're right on schedule. We're doing phenomenal. I hope that was helpful to you watching out there. So we talked a little bit about flapless procedures. We talked about money, how profitable implant dentistry could be. We talked a little bit about, Dr. Tilley talked about sinus elevation, which is a concern for many of us general practitioners out there. Believe me, all these techniques that we've demonstrated so far can be taught. With proper education, high quality education, you can become very proficient and efficient in implant dentistry in your practice. So let's switch gears a little bit. Let's talk about the anterior, the aesthetic zone, the smile zone. And aesthetics are very outcome-based. Both dental and gingival aesthetics act together to provide a smile with harmony and balance. A defect in the surrounding tissue, however, can be compensated by the quality of dental restoration. What does that mean? Well, we've all seen cases where a front tooth just doesn't look right? It looks funny. And we know dentists make it or lab technicians help create it. So oftentimes within the digital age that we live in, we can kind of predetermine what the end result's going to be before we ever start. When I was a young man, I was taught by my mentor, Dr. Mentag, that visualize the case finish before you ever start. And that holds true today. But with our technology, with CBCT, with our software abilities, with our high quality laboratory technicians, we're able to do this, and we really become all equal. I have a lot of experience, but with less experience, we have the ability to make computer generalizations to maximize our aesthetics before we ever touch the patients. So it's an exciting, exciting time to be a dentist. So let's look at this case. Patient presented to my practice with a broken tooth. He had come in from another office with a flipper removal appliance that he was wearing. Wasn't in any pain. So again, Google searched broken tooth, and what comes up? Dental implants. He ended up in my practice. Differential diagnosis. How would you handle this in your practice? Well, some of us may say, let's do a root canal. Post and core, cast post and core. Some of you may say extract it, do a bridge, 3-unit bridge, 4-unit bridge. It's not a right or wrong answer, but dental implants certainly is one of the viable alternatives that we have in our armamentarium today, that patients are coming to us asking for education. And if we're able to restore this tooth, this edentulous area, with a high quality prosthesis, I think we're doing a great service to the patient. But how do we achieve this result? How do we know we're going to achieve this result? So as I mentioned earlier, there are certain rules that must be followed where we ultimately want to place our dental implants. We must have at least 1 millimeter of facial or lingual or palatal bone. That will eliminate the grayness. More is better, less titanium, more bone is better in today's environment. Our implants are very, very, very strong today. So it's very, very important that we follow that rule. We can't be any closer than 2 millimeters to natural teeth or natural PDL, and implants, subsequent implants that are next to each other must be at least 3 millimeters apart because of the lack of blood supply. So these are hard and fast rules that if we start understanding it, it doesn't seem all that complicated once we become a little more proficient in the individual surgical kits that with the system that you choose to use. The papilla level around single teeth implant restorations is mostly related to the bone level adjacent to the teeth, and more specifically to the bone crest. This is a very, very important statement. The peri-implant bone remodeling occurs both vertically and horizontally once the implant is exposed to the oral cavity. What does that mean? We've all seen implants where we have bone shrinkage. Years ago, we would say we expected bone to shrink physiologically to the first 3 threads. That is not unusual or unnatural. With today's engineering, that doesn't happen quite as often as it once did. And there's certain reasons that we're going to discuss in a few minutes. The literature will say that traditionally the radiographic marginal bone loss will occur up to 1.5 millimeters in the first year and then stabilize. And the bone remodeling occurs to accommodate the formation of biologic width around the dental implant. Again, this is a physiologic reaction, so don't beat yourself up too badly. We have to understand the principles. Now, Dr. Tarnow is one of the leading educators in implant dentistry and just a brilliant mind, and he publishes a lot. And I want you to look at this photograph as averages for contact dimensions. And I want you specifically to look between the 2 central incisors. And I want us to all remember the number 4.2. That's very, very important. That's an average of what our contact point or our contact area should be in an ideal situation, 4.2 millimeters. So let's go back to this case. So we have a tooth, and let's determine how you want to handle it. We have a fractured tooth. Some of us may say root canal, cast post and core, the stock post. I know that I do more implants on teeth that have root canals and posts and cores than anything else, I think, in my practice. So the patient wanted to eliminate this tooth, and we decided on a dental implant. As you can see, the tooth was grossly decayed also, and it, had some issues that warranted the extraction. So we did a CBCT analysis, and this is a very, very important sagittal view, cross-sectional view. Let's look at the dimensions. Look at the facial plate of bone, doctors. It's eggshell thin. It's literally eggshell thin. And so it's not uncommon for us to remove this tooth and fracture the facial plate of bone. Now, we can grow bone today, and again, Damon, maybe we'll do a grafting webinar in the future, but let's measure the amount of available height of bone that we have. And it came out to be over 18 millimeters. So there's plenty of vertical bone. Our width is 7.9 or 8 millimeters. So a significant amount of facial, palatal, available bone that we have to work with. But first we have to get this tooth out. And we like to take this tooth out as atraumatically or minimally traumatically as possible. We'd like to keep that facial plate of bone there if possible. Now, how do you remove this tooth? Now, I challenge you that many of us would take some type of periosteal elevator or periotome and go around the tooth to try to break down the periodontal ligament. Fair enough? Yeah. Many of us would take a elevator or a luxator of different designs and see if we could wiggle it mesial distally, place it in the mesial or distal aspect of the tooth and wiggle it. And then I challenge that many of us would probably take some type of anterior forceps, grab onto the tooth, squeeze as hard as we could, do our figure 8 or mesial distal or buccal lingual to try to get that tooth out. Now, when that happens, we often get trauma to the facial plate of bone, which can complicate the situation. What if you couldn't get a purchase point, doctors? What if you just, you couldn't get that luxator on the mesial or distal aspect? Well, I would assume that most of us would take some type of surgical burr, a 557 surgical burr, and trough around the tooth to get a purchase point. Bone is gold to us. It's very, very important to maximize aesthetics, to try to remove this tooth as atraumatically as possible and maintain as much of the hard tissue as possible. Many of you have seen some of my videos or webinars on the use of the golden dent physics forceps. This is an instrument I would not work without. I'm not going to talk too much about it, but it is simply a very specialized instrument. It's really not a forceps. It's more of a luxator. It has two components. A beak, which is a shovel-shaped edge, which will engage the palatal lingual aspect of the tooth 1 to 3 millimeters subgingival. And then the bumper is not the working end of the instrument. It is not holding the facial plate. It is placed as high up the vestibule as possible and simply acts as a center of rotation or a fulcrum. The instrument is never squeezed. Rather, we're simply rotating our wrists, creating tension on the palatal aspect of this tooth. That tension is going to result in a physiologic reaction of the body. The body will release an enzyme which will break down the periodontal ligament. What's holding this tooth in position, doctors? Periodontal ligament, right? So if we're able to remove the periodontal ligament, this tooth will pop up and out of the socket with very, very little force. I'm maintaining the mesial and distal hard tissue and hopefully the facial plate of bone as well. So we remove the tooth and we evaluate. In this situation, I was very lucky. We were able to remove this tooth atraumatically and maintain the facial plate of bone, but that's not the point I want to make here. I always take a radiograph. I see a lot of broken root tips out there, doctors. So this is an instrument, again, that I would not work without. We take a radiograph to ensure that the tooth was taken out in total. Again, going back to the Hahn implant system, we have the 2.4 diameter pilot burr, which is the most important burr in the mouth. I'm using the patient's own tooth to determine the length of implant that we will subsequently want to use. And on the bottom screen here, we have the 4.3 diameter osteotomy burr that will be used to engage the apical aspect of this socket to give us initial stability of our dental implant. So the pilot burr is the most important burr in the mouth, as Dr. Tilley mentioned. And positioning this is very important. Now, again, I like to talk in concentric circles, and we already know that the facial plate of bone was eggshell thin, right? So we don't want to put our implant exactly where that socket was. It's going to create a problem, and it's not going to allow us to have that at least millimeter of facial bone to establish emergence profile and proper aesthetics. So the pilot burr is very precisely placed on the palatal aspect of the socket. We're engaging the palatal aspect of the socket, and we're positioning it about 3 millimeters palatal to the facial aspect of the adjacent teeth. Our initial stability with our dental implants occurs in the apical 2 millimeters. And so that's where we have to have a good bone to allow us to have initial stability for proper integration. I'm again taking my radiographs to ensure proper position. I'm thinking tooth up, doctors. I'm already visualizing what this tooth is going to look like prior to my surgical placement of our implant. We've all had issues with improperly placed implants, which challenges our prosthetic design effectively. So the schematic on the left shows that I'm trying to engage the palatal aspect of the socket, and I'm going to establish my initial stability at the apical aspect of this socket. I'm placing it about 3 millimeters palatal to the facial aspect of the adjacent teeth. Once I establish angulation depth, I'm going to simply widen the osteotomy. It becomes a very simple 5-second procedure to widen that osteotomy. We then widen it a little bit more to accept our final 4.3 diameter wide dental implant. Now, because a socket, I like to tell my patients, when we take a tooth out, we create a socket or hole that's shaped like an egg. Our implant is actually round. So I fill that gap, that gap between the titanium aspect of the implant and the facial plate of bone. I will fill that with a graft material. This happens to be osteogen from Implant Dent. It is a synthetic material of calcium apatite with the same bone characteristics as natural bone. I've done a lot of histology on this. It's just a wonderful, inexpensive grafting material. So it's basically going to act like caulking. So I'm placing this plug into the socket, and then I'm simply going to thread my implant directly into that graft. And what's going to happen is the implant's actually going to push our graft material along the socket sides. The implant is positioned and it actually torqued to 25 Newton centimeters. Because I was able to get initial stability and the patient already came in with a flipper, I decided to go ahead and take an impression at the time of surgery. My positioning of the implant is about 1 millimeter subcrustal into the socket to account for the physiologic bone loss that we will assume we're going to get upon uncovering of the implant. The middle screen shows the sagittal view of the implant in place for education purposes. And you can see the implant was not placed directly into the socket. Rather, it engaged the apical good bone area. We have a good width of available bone on the facial aspect. At the apical portion, you can see I measured 1.1 millimeters. But that's not where we have prosthetic or aesthetic concerns. At the apical portion, it's in the crustal portion where we must maintain 1 millimeter or more of hard tissue. Because the patient was wearing a flipper, I went ahead and put a cover screw and buried the implant. Now, this is an important slide. Dr. Tarnow, again, is brilliant. And he said that the distance from the base of the contact point to the crest of the bone correlates to the presence or absence of interproximal papilla adjacent to the single tooth implant. When this distance is up to 5 millimeters, the papilla was present almost 100% of the time. So if you're able to maintain interseptal bone, and that distance from the tip of the interseptal bone to the contact point is 5 millimeters, you will get an interdental papilla. But if it's greater than 5 millimeters, the interdental papilla formation will be unpredictable. And we want predictability. And doctors, when you're working with a high quality lab, with a high quality implant team, like Livewell Lab, you're going to be able to plan these cases out virtually before you ever start the case. And you can explain and show to your patients what the end results will be. Oftentimes, some of our cases are compromised to some degree. Sometimes it doesn't matter to the patient. They don't have a high smile line, and we're trying to create more function. But in those situations where aesthetics are of paramount importance, then it's important that we work with a high quality lab that understands the principles that we're talking about here today. So I again went back to my measuring tool with our DEXA sensor, and I placed a 13 millimeter long implant. So we measure that, and we can eliminate the foreshortening and elongation that occurs. Now look at the mesial aspect. I'm measuring from the tip of the interseptal bone to the contact point, and I measured 5 millimeters. And what does that mean to all of us here? I want you to start thinking, what does that mean? It means that there's a good chance that we're going to be able to achieve interdental papilla in that area. The distal aspect, you can see that interseptal bone is blunted. I didn't do it. That tooth is, the lateral incisor is malpositioned. So I don't expect to get a good interdental papilla in that area. But in the mesial, right in the front of the mouth, I expect to get a good result. Let's see if we did. Because I took the impression at the time of surgery, I sent it to the lab, and they fabricated a transitional or temporary abutment for me. Everything is CAD/CAM designed today. They can demonstrate that. They can show you these views. You can work with the laboratory technicians to maximize the aesthetics to your eye and to your patient's end result. So they fabricated a transitional custom abutment with scallop margins to maximize emergence profile. And this is just a composite crown that we will use as a temporary. After 4 months of healing, we will uncover the implant. And here again, as Dr. Tilley mentioned, I'm using a tissue punch from Salvin Dental to remove the excess attached gingiva from the cover screw of the implant itself. And you can see our cover screw is in position, and I simply unthreaded it. And I'm going to go ahead and seat my custom temporary abutment. Custom temporary abutment with margins at or slightly subgingival. You can see how this abutment is contoured very similar to a natural tooth root. And this is going to allow us to get good tissue health and concern. We take a radiograph to ensure that our components are fit. This is an important radiograph. You can see with the Hans system, the abutment is placed inside the implant. That's called platform switching, if you want to do a search on that. And what we're trying to do is trick the body physiologically from bone shrinkage, because it doesn't recognize where the margin is. In the past, we would have an implant, and we would have an abutment that would fit closely, but we would have a micro gap right at the bone level. The body says, I don't like it, and it would resorb to one of the first 3 threads. It's not necessarily the case anymore. And most implant systems are designed with a platform switched prosthetic design. We went ahead and we torqued this abutment to place. With the Hans system, we torque it to 35 Newton centimeters. Different implant systems may vary. Now, Glidewell Lab, because the implant isn't totally integrated, it takes about a year for bone to mature completely. And I don't really know how secure that implant is in the hard tissue. So they will fabricate a seating jig for me, which allows me to torque that abutment screw in to 35 Newton centimeters without torquing the implant whatsoever. So a very, very important component with our case. Now, we put this composite crown in. What are you talking about? I can see a dark triangle. We can all see a dark triangle. The shade of the temporary isn't ideal, but we're trying to train the tissue a certain way. Now, what Dr. Tarnow says in his publications is very, very clear. If you walk away, go have a cup of coffee, that tissue will start to rebound very, very, very quickly. The patient wore this temporary for a couple weeks, and you can see how we were able to establish interdental papilla between the 2 central incisors. Not so much on the distal aspect, but I didn't expect that. So we can grow interdental papilla very, very precisely. You can see the crown is basically shaped like a natural tooth. I will then, the laboratory fabricated for me a custom impression coping, which mimics the design of the transitional abutment that we had placed. You can see my contours are exactly the same. We work on the shading a little bit with photography. We replace our custom transitional or temporary abutment. You can see my margins. And if any of you follow my publications, my margins are always at or slightly subgingival for periodontal health. We replace the temporary crown. We send the final impression to the dental laboratory, and you can see the wonderfully periodontally sound healing cuff that we trained with our temporary abutment and temporary crown. The laboratory fabricates a nice zirconia abutment for me, again with margins at or slightly subgingival. We torque this abutment at 35 Newton centimeters. And I'm able to fabricate a nice Bruxer crown. Now, Bruxer in the past we criticized the opacity of it. You can see how it can be customized to a very high level to create emergence profile and smile design for our patients. This is not magic, doctor. This is not anything special other than understanding the principles necessary to achieve a great final result. The tooth is shaped like the natural tooth. Now let's look at some of our measurements. If we look at the distance from the crest of the interseptal bone to the contact point, it's 5.02 millimeters. The distance from the edge of the abutment to the contact point is a little over 2 millimeters. And the contact point, contact area that was created, because our laboratory technicians are so understanding of the principles, was 4.14. Go back to that schematic of averages. We want that contact point to be 4.2 millimeters, ideally. And we were able to achieve that because our technicians are so exceptional in their final design. So we were able to finalize a product that the patient is proud of, that I'm proud of, and we're able to achieve this quite efficiently and effectively and predictably. A high quality dentistry at a fair price. And you too can achieve this type of dentistry very, 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 very nicely.